So, picture this. If a surgeon makes like just a single millimeter scale miscalculation in this geometric space.
Right, the triangle of doom.
Yeah, the triangle of doom. I mean, the patient can literally bleed out on the operating table in a matter of minutes.
It's incredibly fast.
Right. We are talking about like a microscopic slip of an instrument, and it triggers this catastrophic hemorrhage from the main blood supply to the leg.
All well buried deep inside this claustrophobic, artificially inflated pocket in the human pelvis.
It's terrifying. And today we are taking you inside one of the most perilous, but also elegantly engineered operations in modern medicine.
It's completely counterintuitive, really.
Totally. It's called the totally extraperitoneal repair, or TAP.
And, the goal for you today is to learn how surgeons engineer a cure by, well, creating a space that doesn't actually naturally exist.
Right. They just make it out of thin air. Or, well, gas. And for this deep dive, we are pulling from an operative masterclass from the Surgical Thinking Academy.
Specifically, their hernia surgery series.
Yeah.
It's a brilliant breakdown of surgical thinking.
It really is, because we're looking at a surgical philosophy that completely inverts how we treat physical trauma.
Exactly. I mean, instead of confronting a blowout directly from the front where the structural failure is, obvious.
Where you can literally see the lump.
Right, where the lump is. The modern approach is to tunnel behind the entire pelvic architecture.
So we are fixing a forward-facing blowout, like from behind.
Yes.
Okay, let's unpack this, because you have a patient presenting with an inguinal hernia, right? That's a mass of visceral fat or intestine literally pushing out through the abdominal wall.
Pushing toward the skin, yeah.
And the natural instinct, like for a century, was to slice into the front of the groin.
Because that's where the problem looks like it is.
Right. You push the mass back in, and you try to sew the torn edges of the muscle together.
Which failed relentlessly.
Which constantly fell apart.
Because those early tension repairs, they were biologically doomed. They totally ignored the underlying biomechanics of the human pelvis.
Wait, what do you mean by biologically doomed? Like, why doesn't sewing it up work?
Well, think about it. You forcibly pull two different edges of tissue together under tension.
Right.
Tissue that has already, demonstrated structural failure.
Yeah.
And then you subject it to the daily load of coughing, lifting, just walking upright.
Oh, man, so the stitches just rip.
Inevitably. They rip right back through the fascia like a wire pulling through warm butter.
Oh, wow. That is a visceral image.
Uh.
So to understand the genius of tunneling behind this defect, we first have to look at the architectural flaw in the human body.
The overarching vulnerability.
Yeah, because the groin is a massive structural liability. And it really comes down to the evolutionary cost of bipedalism, doesn't it?
It does. The transition to walking upright on two legs fundamentally altered the mechanical stress on our lower anatomy.
Because before that, we were on all fours.
Exactly. In quadrupedal mammals, the abdominal weight is suspended like a hammock. It's distributed evenly across the robust rectus and oblique muscles of the belly.
So the strong muscles take all the weight.
Right. But when humans stood up, our pelvis tilted.
And gravity just shifts everything.
Yes. The lower groin was suddenly subjected to the full, relentless hydrostatic column of intra-abdominal pressure.
Just all that weight pressing down on the bottom of the bowl.
Every single time you lift a heavy object or even cough, that pressure spikes. And the kinetic energy, it just looks for the path of least resistance to escape.
And for centuries, surgeons were treating the different escape routes as entirely different diseases.
Which is wild in hindsight.
Yeah. I mean, if the blowout happened in one specific anatomical canal, they called it an indirect inguinal hernia.
Right.
If it pushed straight through the floor, it was a direct inguinal hernia.
And if it tracked lower, down by the leg vessels, it was a femoral hernia.
3 distinct diagnoses, 3 completely different operations.
Until a French surgeon named Henri Frouchot came along and basically broke that dogma.
Frouchot, he's kind of a legend in this space.
He really is. He looked past the specific exit points and analyzed the broader biomechanical landscape.
So instead of playing whack-a-mole and patching 3 different cracks in a dam, Frouchot realized the entire wall is the problem.
Exactly. He mapped out this singular, vulnerable anatomical window that encompasses all of those different exit routes.
The myopectoneal orifice.
The myopectoneal orifice. It's this massive, oval-shaped defect inherent in human anatomy.
But how big is this window, really? Can one patch actually cover all of those spots?
It can. If you look at the anatomy outline in the master class, the roof is formed by the arching fibers of the internal oblique and transversus muscles.
Okay, so that's the top.
Right. And the floor is anchored by the bony pubic ramus and the unyielding pectineal ligament.
Which surgeons usually call Cooper's ligament, right?
Yes, Cooper's ligament. Then the inner or medial border is the edge of the rectus muscle.
The six-pack muscle.
Exactly. And the outer lateral edge is the iliopsoas muscle.
So it's essentially this large bay window in the lower pelvis.
And it's split right across the middle by the inguinal ligament.
Okay, so that split divides it into an upper half where you get the direct and indirect hernias, and a lower half for the femoral hernias.
Precisely. And across this entire sprawling frame, the only primary barrier holding your organs in is a fragile, micro-thin membrane.
The transversalis fascia.
The transversalis fascia. Every single groin hernia is a failure of this specific fascia.
So the logic shifts completely. You don't patch the little hole where the tissue ruptured.
Because that's just a localized fix to a systemic problem.
Right. If the entire window is mechanically compromised by the physics of walking upright, the only durable solution is to reinforce the whole frame.
You lay a massive prosthetic mesh behind the entire myopectineal orifice,
From the inside.
covering the direct space, the indirect space, and the femoral space all at once.
It's like you're preemptively curing hernias the patient hasn't even developed yet.
That's the exact philosophy. Cover the orifice and recurrence has nowhere to go.
But okay, here's where it gets really interesting. Because if you need to cover this entire window from behind, you run into a huge physical problem.
There's no empty room back there.
Right. There's nowhere to stand and work. So the surgeon basically has to build their own operating room inside the patient's abdominal wall.
They have to create what we call a potential space.
A potential space,
Yep.
meaning it's not actually a space until you force it to be one.
Exactly. It's the preperitoneal space. It sits between the transversalis fascia in the front and the peritoneum in the back.
And the peritoneum is like a heavy, fluid-filled balloon that holds all the intestines, right?
Yes. And in a resting body, this space between the fascia and the balloon is completely collapsed.
So getting into this space, it's kind of like sliding your hand between a poster and the wall and trying to cleanly lift the poster off without tearing the paper.
That is a perfect analogy because the peritoneum is incredibly delicate.
So how do they actually get in there and do it?
Well, the surgeon starts with an infraumbilical incision, right below the belly button.
Okay.
They drop down behind the rectus muscle, but they have to stay outside the peritoneum.
They don't want to pop the poster, so to speak.
Right. And once they find that exact plane, they introduce a dissection balloon.
Just like a physical balloon.
Yes, an uninflated, blunt-tipped elastomer device.
Yeah.
They manually tunnel it down the midline, aiming straight for the pubic bone.
Wow.
And when it reaches the bone, they inflate it, usually with saline or air.
And as it expands, it just peels the peritoneum backward.
Exactly. It acts as a blunt hydraulic wedge. It sweeps open the retropubic space, which is historically called the space of Retzius.
The space of Retzius, that's right in front of the bladder, right?
Then they deflate the balloon, angle it outward toward the side, and inflate it again to open the space of Bogros.
So they merge these two spaces, Retzius and Bogros, to artificially excavate a cavern that covers the whole myopectineal orifice.
They do, but you can't leave a balloon in there to operate.
Right, because you need to put instruments in. But the moment you take the balloon out, wouldn't the heavy organs just crush the space back down?
They would, which is why the surgeon seals the incision with a port and pumps the cavity full of carbon dioxide gas.
Ah, the pneumoperitoneum.
Exactly. Regulated at a very low pressure, typically between 10 to 12 millimeters of mercury.
And that gas acts like invisible scaffolding. It holds the chamber open so the surgeon can work.
And that is the literal definition of totally extraperitoneal. The surgeon operates inside this pressurized gas bubble entirely within the abdominal wall.
They never actually enter the main belly cavity.
Never.
Which sounds great until you realize how fragile that space is.
Yeah.
Because the expert in the master class issues a major warning about tearing the peritoneum.
Yes. The integrity of that membrane is the single most critical dependency of the operation.
Because if you accidentally tear the poster, the peritoneum, what happens?
It's a disaster for visibility. The CO2 gas instantly escapes your little working bubble and floods into the main abdominal cavity.
Oh no. So the pressure equalizes.
Worse. The main cavity fills with gas, and it exerts this overwhelming pressure pushing forward.
Pushing the peritoneum right back into the surgeon's camera.
Exactly. The membrane billows toward you. It systematically crushes the preperitoneal working space.
They call it the shrinking box scenario, right? The
Uh-huh.
surgeon is suddenly trapped in a collapsing tunnel where visibility just drops to zero.
It is incredibly disorienting.
I can't even imagine. So let's say they don't tear it. They're inside the bubble. The space is open, but they're just staring at a landscape of yellow fat and white connective
It's
tissue.
completely alien. Navigating this space requires rigid adherence to fixed landmarks.
Because you're looking at the reverse side of the groin. Everything is backwards.
Right. It's akin to cave diving in low visibility water. If you lose your guide wire, you can drift into fatal hazards.
So how do they find true north?
They have a strict sequence. Anchor number 1 is the pubic symphysis.
The midline pubic bone.
Yes. They sweep through the fat until they visualize the gleaming white bone. From there, they trace outward to find anchor number 2, Cooper's ligament.
That tough white pectineal ligament we mentioned earlier.
Identifying Cooper's is non-negotiable. It immediately tells the surgeon where the femoral canal is.
Okay, so that maps the floor. What about the roof?
For the roof, they look for the great divider, the inferior epigastric vessels.
The epigastric vessels. And these are crucial for classifying the hernia from the inside, right?
Exactly. If the hernia defect is medial toward the midline of those vessels, it's a direct hernia.
And if it's lateral toward the outside, it's an indirect hernia.
You've got it.
Ah.
Following that map laterally, they find the deep ring, which is where all the cord structures converge.
Right, the vas deferens sweeping in from the middle and the gonadal vessels coming down from the outside.
They meet at the deep ring to exit the abdomen.
And the masterclass puts a massive emphasis on seeing all of this clearly. We talk about the critical view of the myopectineal orifice.
They borrowed that concept from gallbladder surgery.
The idea that you need a strict visual checklist before you do anything permanent.
Exactly. The modern standard demands that you clearly see the pubis, Cooper's ligament, the direct space, the indirect space, the femoral space, and the parietalized cord.
You earn the right to place the mesh by first seeing everything you must cover. That's the quote.
It's a great philosophy,
Yeah.
because laying a mesh blindly is a guarantee of a complication.
Which brings us to navigation, because it isn't just about knowing where to go, it's about knowing exactly where not to step.
The danger zones.
Yes. What's fascinating here is how beautifully and terrifyingly the body's vulnerabilities are clustered.
They've literally given them theatrical names to warn surgeons.
Right. Let's start with the most dramatic one, the Triangle of Doom.
It is exactly as serious as it sounds.
So what are the borders of this triangle?
The inside border is the vas deferens, the outside border is the gonadal vessels, and the apex is the deep ring,
It's an inverted V, and what's inside it?
the external iliac artery and vein.
The main blood supply to the leg.
Yes. And the walls of that vein are surprisingly delicate. If a stray tack or instrument punctures that vein, the hemorrhage is instantaneous.
And you're in a tiny claustrophobic gas bubble.
Right. You cannot easily control major bleeding laparoscopically in that space. The patient can exsanguinate right on the table.
Absolute nightmare. So rule 1, stay out of the Triangle of Doom. But then just medial to that, there's another zone, the corona mortis.
The crown of death.
Also incredibly dramatic. What is the crown of death?
It's an abnormal vascular bridge, a vein or artery that connects the obturator and external iliac systems,
And the problem is its location, right? Because it runs right over Cooper's ligament.
which, as we said, is the primary safe anchor point for the mesh.
But this vessel is only present in a large minority of people, right? Not everyone has it.
Exactly. Up to a third of patients. So if a surgeon blindly tacks into Cooper's ligament without cleaning off the bone to look for it first,
I could tear the corona mortis.
and cause sudden torrential bleeding, which is, again, incredibly hard to control because the vessel retracts back into the bone.
Okay, so we have 2 zones of lethal bleeding, but there's a third zone that has completely changed how surgeons think about success.
The triangle of Pan.
The Triangle of Pain, where is this one?
It's located lateral to the gonadal vessels below the iliopubic tract.
So on the outside, lower down, and unlike the other 2, there aren't major blood vessels here.
No, it won't kill the patient, but it is densely packed with sensory nerves.
The lateral femoral cutaneous nerve, the femoral branch of the genitofemoral, the femoral nerve itself.
Yes, and if a surgeon puts a tack into one of those nerves, they condemn the patient to years of agony.
Moralgia paresthetica.
It's a debilitating neuropathic syndrome. Constant burning, radiating pain down the thigh.
We were talking about this earlier, the tool belt analogy. It's like wearing a heavy tool belt that's permanently cinched too tight across your hip bone.
And every time the patient walks, the mechanical tension pulls the nerve against the metal tack.
Which sounds unbearable. The patient would literally beg for the hernia back if it stopped the pain.
They absolutely would. And this fear of the triangle of pain has fundamentally shifted the entire philosophy of hernia surgery.
Because historically, surgeons were terrified of the hernia coming back. Recurrence was the enemy.
So they would aggressively anchor the mesh with dozens of tacks.
Like nailing down a carpet at every corner. But if you have this massive mesh covering all these vital structures, shouldn't you be stapling it down securely so it doesn't move?
That was the old thinking. But that aggressive fixation caused all this chronic pain, so surgeons had to find a better way.
And this is my favorite part of the whole deep dive, the aha moment, because they realized they didn't need to tack it at all.
Thanks to Pascal's principle.
Right, because the surgeon placed the mesh behind the abdominal wall inside that bubble.
Yes. So when they let the gas out of the bubble, the pressure inside the belly, the exact same pressure that caused the hernia in the first place.
Now pushes the mesh perfectly flat against the wall.
Exactly. The massive hydrostatic pressure of the internal organs acts as a uniform, omnidirectional clamp.
The enemy becomes the repair's best friend. The outward force of the body permanently locks the cure into position.
It's brilliant. It birthed the modern dictum. The safest tack is the one you never place.
So fixation is minimal or none at all now, but if they absolutely have to use a tack, there's a golden rule.
The ultimate surgical law. No fixation lateral to the inferior epigastric vessels.
And no tack below the iliopubic tract.
Right. You only tack medially into Cooper's or superiorly high up.
Keep the metal out of the triangle of pain.
Exactly.
Okay, so having mapped the space, identified the enemies, and established the geometric rules, let's actually walk through the choreography of the operation.
Step by careful step.
We've distilled this into 9 steps from the masterclass. Step 1 is access, making that infra-umbilical incision and dropping behind the rectus muscle.
Step 2 is the balloon, sweeping retius and bogros open.
Right, building the bubble. Step 3 is adding the structural ports for the working instruments.
Step 4 is developing the space, exposing all those landmarks we just talked about.
And then step 5, deal with the hernia. And this changes depending on the type of hernia.
Yes. If it's a direct hernia, it's essentially a pseudosac. It's just a blowout of stretched fascia.
Like the inverted fabric of a pocket. You just pull it back out.
Exactly. You just grasp it and pull it back into the preperitoneal space.
But that leaves a pitfall, doesn't it? Because when you pull that massive pocket out, you leave an empty void in the groin.
A dead space. And nature abhors a vacuum. That space will fill with fluid, creating a seroma.
Right. And from the outside, a seroma looks exactly like a recurring hernia. A big, squishy lump.
Which causes the patient severe anxiety. They think the surgery failed instantly.
So the surgeon has to warn the patient beforehand. You will get a fluid lump. It's normal. It will go away.
Absolutely vital patient education.
Now, what if it's an indirect hernia? That's not just a pseudosac.
No, an indirect sac is a true piece of the peritoneum that has tracked down the spermatic cord. It's an embryological remnant. The processus vaginalis.
Right. And it's densely glued to the vas deferens and gonadal vessels. So you can't just yank it.
You have to meticulously peel it off the cord structures.
Yes, drawing it back up into the abdomen. And if it's massive, extending way down into the scrotum, they don't even try to pull it all out.
Because it would damage the blood supply to the testicle.
Exactly. So they tie it off, cut it, and leave the bottom part in the scrotum to safely scar down.
Wow. Okay, so after the sac is managed, we hit step 6. And the masterclass highlights this as the step trainees always skip.
Parietalization of the cord.
Parietalization. Why is this so crucial?
Because if you don't do it, the hernia comes back. When you pull the sac back, the peritoneum is still draped over the vas and the vessels.
Like a tent.
Right. And if you lay the mesh over that, the daily mechanical pulling of the psoas muscle will drag the peritoneum right under the edge of the mesh.
It slides under the mesh, causing an early recurrence.
Exactly. So you have to parietalize. You systematically detach the peritoneum from the cord until it reaches all the way past the psoas muscle. You essentially drop the cord to the floor and push the peritoneal balloon to the ceiling.
Yes. So the mesh lays flat on the cord, and the peritoneum rests securely on top of the mesh.
That makes perfect sense. And during this step, they also have to watch out for another named pitfall, the missed cord lipoma.
Yes, a fatty lump lateral to the cord. If you don't remove it, it will slide down later and mimic a hernia.
It'll feel just like a hernia to the patient. Okay, so step 7. The mesh, and we're talking about a massive piece of material.
Usually at least 10 by 15 centimeters, sometimes bigger. It has to cover the entire myopectoneal orifice completely flat.
And step 8 is fixation, or Rather, the lack of it.
Right. Minimal or none. Maybe some surgical glue or self-gripping mesh just to keep metal out of the triangle of pain.
Which brings us to the final critical choreography, step 9, desufflation.
Letting the gas out.
They can't just pull the plug, right? It has to be slow.
Very slow. Because as the gas leaves, the heavy peritoneal balloon drops back down.
And the surgeon has to hold the bottom edge of the mesh with their graspers to keep it perfectly flat.
Because if the descending balloon catches a corner of the mesh, it folds it over.
And a folded mesh is an instant pathway for a recurrence.
Right. They have to watch it carefully until the pressure locks the sandwich together.
It's honestly a breathtaking sequence when it goes perfectly.
It really is.
But even the best map can't prevent every storm. What happens when the shrinking box scenario actually happens?
When the peritoneum tears.
Yeah. When visibility drops to 0, how do they bail out?
Well, the mark of surgical judgment is choosing the right operation, not pushing a failing one. You don't panic. You follow a ladder of bailouts.
What's the first step on the ladder?
You try to vent the rogue gas from the main abdomen. You insert a varus needle, a specialized venting needle, straight into the belly.
So that lets the pressure out of the main cavity, which hopefully lets the working bubble expand again.
Exactly. And if you get your space back, you try to close the tear. You use endoscopic loops or sutures to sew the hole shut.
But what if the tear is just too big or it's down by those dangerous iliac vessels?
Then you execute the ultimate bailout. You convert to a TPP procedure.
TAPP, the transabdominal approach.
Right. You intentionally enter the main abdominal cavity.
So you completely abandon the extraperitoneal bubble.
Yes. Because once you're inside the main cavity, the tear in the membrane doesn't matter anymore. You just open a slot from the inside, lay the mesh, and sew it up.
Choosing the right operation is a mark of judgment, not defeat. That's a powerful takeaway.
It saves lives.
So if we connect this to the bigger picture, where is this philosophy going? Because technology is advancing this specific extraperitoneal approach, right?
Rapidly. For one, the mesh materials are evolving. We're moving toward lighter, large, pore meshes.
Better tissue integration?
Yes, less rigid scar tissue, which means less chronic sensation for the patient.
And they're even making 3D contoured meshes now, right?
Yes. Pre-shaped to the exact curve of the myopectoneal orifice. They just snap into the pelvic bowl and sit flat without folding.
Which means 0 fixation required.
Exactly.
But the most exciting trend mentioned in the source material is the ETEP, the extended view TEP.
Pioneered by Jorge Dace. It's revolutionary.
Because they're taking this tiny claustrophobic bubble technique from the groin and scaling it up to the whole abdomen.
They are. They dissect the retrorectal spaces behind the abdominal muscles to create a massive, roomy working space.
To fix massive ventral hernias on the front of the belly.
Yes. It allows them to place enormous meshes without ever entering the main abdominal cavity, avoiding all the bowel adhesions and scar tissue.
And they are using robotics for this now too, right?
Robotics are a huge asset here. The 3D vision and wristed instruments give incredible precision for this delicate dissection, though they often use it via the TAPP approach right now.
So what does this all mean? It seems like safety and patient comfort are converging on the exact same answer.
Bigger, flatter, lighter meshes with less and less fixation.
Okay, let's build our memory palace and lock in the core journey for you. It all starts with one unifying theory.
Frischaud's myopectoneal orifice. One weak spot for all groin hernias.
To fix it, you build one artificial bubble.
Sweeping open the spaces of Retzius and Bogros.
You navigate a strict map to earn the critical view.
Avoiding the catastrophic triangle of doom in the corona mortis.
And you completely refuse to staple into the triangle of pain.
Instead, you parietalize the cord and lay a massive mesh flat.
Letting the body's own internal pressure hold the cure in place.
A beautifully engineered solution.
It really is. And it leaves us with a provocative thought to mull over.
Ugh.
Yeah, because we just spent this time learning how surgeons use the very force that caused the intra-abdominal pressure to permanently secure the cure.
Right, inverting the mechanism of destruction.
Exactly. It makes you wonder, what other destructive forces in human biology or, even in our physical environment are just waiting for a slight shift in perspective to be transformed into the exact tool needed for repair?
That is a fascinating concept. The energy is already there. We just need to change the architecture to harness it.
Exactly. Just flip the polarity. Thank you for joining us on this deep dive. Keep questioning the obvious and keep exploring the brilliant engineering hidden inside yourselves.